All right, a pleasant good night to everyone. I'm Dr. Ramsanuj. Tonight we'd be discussing embryology of the brain. So in essence, the objectives of tonight's presentation is really to discuss the embryology of the brain, basically its development and its derivatives, as well as to review the anomalies, as well as certain clinical correlates without going too much into detail. So in terms of the nervous system, the study of the development of the nervous system, it really helps us to understand the complex organization as well as the occurrence of various congenital anomalies. The specific cell population of early ectoderm that gives rise to the entire nervous system and special sense organs would be termed neural ectoderm. And then as we go on, we would see that this later differentiates into three structures. The vitals one being the neural tube, the neural crest cells, and the ectodermal placodes. So back to the very basics in terms of the stages of the neural tube formation. And what this picture here outlines is basically how we even get to the neural tube. So we know that the neural tube develops in two ways, really the primary neurulation as well as secondary neurulation. And what actually happens is that in primary neurulation, you have the ectoderm being divided into internally the neural tube that we would see here, externally the epidermis, as well as the neural crest cells. So the neural crest cells basically develop in the region between the neural tube and the epidermis. So just to simplify it a little bit, what you have happening, you have a neural plate that is formed, and then the edges of this neural plate begins to thicken and lift upwards. And then we see that it forms these neural folds that are outlined in blue and green. And then the center of that neural fold remains grounded, but you end up having a U-shaped neural groove being formed. And what this does is that it sets the stage, or it sets the boundary for the right and the left sides of the embryo. Once these neural folds pinch together, they form the neural tube. And it's important that we remember at this point that the anterior neural pore closes on day 25 and the posterior on day 28. And that becomes vital when we get into the different congenital anomalies. So the neural ectoderm, as we outlined earlier, differentiates into the neural tube, the neural crest cells, and the ectodermal placodes. As it pertains to this presentation, we'd be looking at the neural tube, which gives rise to the central nervous system. So basically, this neural ectoderm is the genesis of the brain and the special sense organs. So when these neural folds fail to fuse at the midline to form the neural tube, then is when we can end up with neural tube defects, which can be intense birth anomalies that occur basically between 21 to 28 days after conception. So like we would have been mentioning, the brain develops from the enlarged cranial part of this neural tube that we've been speaking about. The brain begins to develop in the third week. The neural tube, which is cranial to the fourth pair of somites, it develops into the brain. And then at about the end of the fourth week, this enlarged cephalic part then shows three distinct dilatations called the primary brain vesicles. So fusion of the neural folds that we would have been speaking about earlier in the cranial region and closure of the rostral neuropore forms or allows these three primary brain vesicles to form. So craniocaudally, as we continue into the development of the brain, you're going to have these three vesicles, the prosencephalon or the forebrain, the mesencephalon or the midbrain, and the rhomencephalon or the hindbrain. Then what we'd see is that their cavities then form the ventricular system of the adult brain. During the fifth week, so all of this would have happened, third to fourth week. And then during the fifth week, we have the prosencephalon and the rhomencephalon subdivided into two vesicles, thus producing 5 secondary brain vesicles. And this is a pictorial representation of what I would have been saying, that you have your 3 primary brain vesicles, your prosencephalon, your mesencephalon, and your rhomencephalon. And further, the prosencephalon then gives a rostral teleencephalon and a caudal diencephalon, and we see them as per the color scheme. The teleencephalon now, what it does is this is going to develop lateral diverticula by evagination, which are then going to enlarge and overgrow and cover the caudal diencephalon that we're seeing, right? The caudal diencephalon to form what we will then know as the cerebral hemispheres. So the diencephalon really thus becomes hidden in the lower parts of the cerebral hemispheres and then forming the thalamus, the hypothalamus, and the epithalamus. The mesencephalon, which is outlined in green, this gives rise to the midbrain. Now, this really doesn't show much changes in early parts of development, except that the cavity tends to get progressively narrowed to form the cerebral aqueduct. The rhombencephalon, or the hindbrain, which is the third primary vesicle, this then divides rostrally to form the metencephalon, which is going to eventually develop into your cerebellum and your pons, and your caudal myelencephalon, which would then give rise to your medulla oblongata. Again, for the purposes of the description, we have the adult derivatives of the brain vesicles that we would have just gone through previously on the previous slide. So prosencephalon, in essence, gives you cerebral hemispheres, as well as your thalamus, your hypothalamus, your epithalamus. And in terms of your ventricular system, you get your lateral and your third ventricles. Your mesencephalon gives you midbrain and your cerebral aqueduct, and your rhombencephalon, your pons, cerebellum, medulla oblongata, and it gives the fourth ventricle. The other important thing that we need to touch on when we think about the development of the brain would be the flexures of the brain. So the primitive brain presents three flexures, and that is your cervical flexure, which is at your junction of your rhombencephalon and your spinal cord, and your cephalic flexure in the region of the midbrain, as well as your pontine flexure at the middle of the rhombencephalon. So what becomes important with this is that based on these flexures, they help the brain to assume a configuration as a result of the differential growth of these vesicles and flexures. So if we notice, the cephalic flexure and the cervical flexure are concave ventrally, whereas the pontine flexure exhibits a ventral convexity. So that cervical flexure that makes a 90-degree bend that we can see between the hindbrain and the spinal cord causes the brain to be oriented almost as a 90-degree angle to the spinal cord. I would have mentioned the pontine flexure as well. And what this is important as the hindbrain, it becomes folded at the middle so that it forms an acute angle ventrally. And then this cavity becomes a diamond-shaped space, as we can see in this diagram, which then goes on to form your fourth ventricle, because that diamond-shaped space is going to taper superiorly to narrow canal of the midbrain and the aqueductus sylvius, and inferiorly to the central canal in the lower part of the medulla oblongata. That thin roof that we're seeing is pulled out to cover the space posteriorly, and the line of folding is going to extend far laterally as a roof of the lateral recesses of the fourth ventricle. Now, why would these lateral recesses be important that are derived by the pontine flexure? Is that the tips of these recesses and the inferior angle of the ventricle, the thin roof is going to break down. When it breaks down, it forms the apoptose. That is the lateral foramen of Luschka and the median foramen of Magendie, through which the cavity of the neural tube then communicates with the surrounding subarachnoid space. So to delve deeper, we'll start with the prosencephalon, or the forebrain. So the forebrain basically develops from the forebrain vesicle. So at an early stage, you're going to have a lateral diverticulum called the optic vesicle appearing on each side of the forebrain. That part of the forebrain that lies rostral to the optic vesicle is the teleencephalon, and the remainder is the diencephalon, as we would have seen in the images previously. Ultimately, the optic vesicle and the stalk will form the retina as well as the optic nerve. So the teleencephalon, which is the first part of the prosencephalon, like we would have mentioned, it forms the anterior end of the third ventricle, which is closed by the lamina terminalis. And this lamina terminalis that we see outlined in the diagram represents the rostral end of the neural tube. So when it is closed by the lamina terminalis, what you have happening is the diverticulum on either side is going to become the cerebral hemispheres. So each cerebral hemisphere, in essence, is going to arise at the beginning of the 5th week of development. Now, these cerebral hemispheres, so the medial wall of the cerebral hemisphere is going to remain thin, and it's formed by your ependymal cells. It then becomes invaginated by your vascular mesoderm to form your choroid plexus of your lateral ventricle. And then coming towards the back, you have the occipital lobe of the cerebral hemisphere, which is going to be separated from the cerebellum by mesenchyme, which condenses to form what we know as the tentorium cerebri, sorry. So meanwhile, while all of this is going on, you're going to have your matrix cells lining the floor of the forebrain vesicles still proliferating and producing your neuroblasts. And this is an image showing your successive stages in the development of the cerebral cortex. So as we see from the beginning in pictures in the photo A, where it's smooth, so basically it expands superiorly, the walls become thicker, and the interventricular foramen that we see here is going to reduce in size. The mesenchyme between each cerebral hemisphere, then condenses to form your falx cerebri. As development proceeds, what you have happening is these cerebral hemispheres are going to grow and expand rapidly, firstly anteriorly to then form your frontal lobe, as we know, and then laterally and superiorly to form your parietal lobes, and finally, posteriorly and inferiorly to produce your occipital and your temporal lobes. So as a result of this expansion, the hemispheres then cover the midbrain and the hindbrain. So just to touch a little bit more on the cerebral hemisphere, this is the coronal section of your cerebral hemispheres that you're going to see the choroid plexus, which would in the third and the lateral ventricles. Because remember, as much as we're speaking of the adult derivatives, we need to remember that they also contribute to the ventricular system. So you have the matrix cells lining the floor of the forebrain. These proliferate and they produce neuroblasts. And then collectively, they're going to form a projection that encroaches on the cavity of the lateral ventricle, known as the corpus striatum. And then these later differentiate into two parts: your dorsal medial portion, your caudate nucleus, and then your ventrolateral part, your lentiform nucleus. So it's important that we stop to recognize at this point that the corpus striatum appears during the 6th week, basically as a prominent swelling in the floor of each cerebral hemisphere. The floor of each hemisphere expands more slowly than the cortical walls because those are thinner, but it contains the corpus striatum that consequently you could see the lentiform becoming subdivided into a lateral part, which would be your putamen, and a medial part, the globus pallidus. So again, this is just a summary slide more or less of the medial surface of the forebrain of a 10-week embryo, showing the derivatives that we've spoken of so far, showing the main commissures, and more importantly, showing our cerebral cortex that we would have spoken about, as well as your lentiform nucleus, your hypothalamus. So it really, what this is showing us is the developing relationship of the cerebral hemispheres to the diencephalon. Sorry. So as the cerebral hemispheres expand, they're going to cover successively the diencephalon, the midbrain and the hindbrain. Now, eventually what you have happening is the hemispheres are going to meet each other in the midline, flattening the medial surfaces. And that mesenchyme that is going to be trapped within that longitudinal fissure gives rise to the cerebral falx, or the falx cerebri, like we know, which is really a median fold of dura mater. And then immediately above the choroid fissure, or the medial wall of the hemisphere, thickens to form the hippocampus. Now, the second picture, which you're seeing on the right, this becomes important because what is happening is with the expansion of the cerebral hemispheres that we spoke of, the hippocampus is going to become displaced posterior inferiorly into the lateral ventricle. You have your corpus striatum developing, like we would have just mentioned, in the floor of the diencephalon, adjacent, as we can see, to the thalamus and the hypothalamus, right? So primitively, these areas of gray matter, the corpus striatum, sorry, are sensory motor control sensors. So I'm hoping that, this really shows you how everything is coming into play. And the axons from the large ascending and descending tracts, which as they develop, are then forced to pass between the thalamus and the caudate nucleus medially. So it passes between your thalamus and your caudate nucleus medially and the lentiform nucleus laterally. This compact bundle of ascending and descending tracts is known as the internal capsule. So the other important thing that we need to know as we go on with the development of the brain is the cerebral commissures. So basically, as the cerebral cortex develops, you're going to have these group of nerve fibers, which are commissures that connect corresponding areas of the cerebral hemispheres with one another. So basically, you have a lamina that extends from the roof plate of the diencephalon to the optic chiasm. And this lamina is a natural pathway from one hemisphere to the other. So the most important of these commissures cross the lamina terminalis, which we would have seen earlier, I would have outlined, is the rostral or the anterior end of the forebrain. And we know that the largest cerebral commissure is the corpus callosum, which connects your neocortical areas. So initially, the corpus callosum really lies in the lamina terminalis, but as your fibers are added to it, as the cortex enlarges, it gradually extends beyond the lamina terminalis, and you have a third commissure developing, right? And we'd see the rest of these commissures in your next picture. So as we can see here, you're going to have the corpus callosum, as I would have outlined, being the largest. You also have your anterior, your posterior, as well as your hippocampal commissure. So the first commissure to actually form is the anterior commissure and the hippocampal commissure. And what these are, they're really just small fiber bundles that connect the older parts of the brain. The anterior commissures connects the olfactory bulb and related areas of one hemisphere to the other. The hippocampal commissure connects the hippocampal formations. And then your posterior commissure lies at the dorsal end, which we could see here. It lies at the dorsal aspect of the rostral end of the cerebral aqueduct, and it forms a bridge between both cerebral hemispheres, allowing communication across the midline. Now, the posterior commissure tends to be important in several aspects. It's responsible for that bilateral pupillary light reflex. It also has a role to play in language processing. It connects the language-related centers in both cerebral hemispheres as well. Now, still on the cerebral cortex, we know that the surface, as we would have seen in a couple pictures a few back, the surface of the cerebral hemispheres is smooth. But as growth proceeds, you're going to have sulci and gyri developing. And we know sulci is your grooves between your gyri. Your gyri tend to be those tortuous convolutions that you see, and that occurs because of infoldings of the cerebral cortex. And then as each cerebral hemisphere grows, the cortex covering the external surface of the corpus striatum, it grows relatively slowly, but it becomes soon overgrown. And when that happens, you're going to have a buried cortex, and that buried cortex, which is hidden from the views of the depths of the lateral sulcus of the cerebral hemisphere, is then known as the insula. So one of the important takeaways also is that, these sulci and gyri, they permit a considerable increase in the surface area of the cerebral cortex without requiring an extensive increase in the size of the neurocranium per se. So these are just sketches of lateral views of the left cerebral hemisphere, your diencephalon, and your brainstem. And what this really is to show you the development. Basically, in picture A, this would have been in a fetus at 14 weeks, in B at 26 weeks, in C at 30 weeks, and then at D at 38 weeks. And what that shows you is you're seeing the actual surface of the cerebral hemisphere forming these convolutions as well as the grooves, your sulci and your gyri. Again, this is to show you the lateral view of the brain of a stillborn fetus in A at 25 weeks. And we see we're still seeing a little bit of smoothness. And then in B compared to C, what we characteristically picture as the brain. So moving on to the diencephalon. The diencephalon, it develops from the median portion of the prosencephalon, as I would have said. It consists of two thick lateral walls, a thin roof, and a floor plates. And you have three swellings developing in the lateral wall of the third ventricle, which then become your thalamus, your hypothalamus, and your epithalamus. And of course, we would have mentioned that the cavity that is going to become is the third ventricle. So, like we would have just said, each lateral wall presents a sulcus, right? So you see the hypothalamic sulcus separating the hypothalamus from the thalamus, and then you have your epithalamic sulcus separating your epithalamus from your thalamus. So you actually also have at this point, you have a down growth from the floor of the anterior hypothalamus, the neurohypophysis, which joins an upgrowth from the adenohypophysis to form the pituitary gland. So this is why this becomes important at this point, and we will touch on that a little bit later. So just to recap on where we are. The development of the brain. We talked about the 3 primary vesicles. We talked about the 5 secondary vesicles. So we've covered our forebrain in terms of the telencephalon and the diencephalon and their different derivatives. So we're going to move on to the mesencephalon, the metencephalon, and the myelencephalon. And while incorporating the development of the ventricular system within the presentation. So the cavities of the brain vesicles, as I would have said, would have formed the ventricular system of the adult brain. The hindbrain cavity becomes the fourth ventricle. The narrowed mesencephalic cavity becomes the cerebral aqueduct. And the diencephalic cavity becomes the third ventricle. And the twin telencephalic cavities become your lateral ventricles. So the thin roof of the fourth ventricle is covered by your pia mater that is derived from mesenchyme associated with your hindbrain. Then you have the vascular membrane together with this ependymal roof. It's forming the telochoroidea of the fourth ventricle. And you have invagination of the fourth ventricle where it then differentiates into the choroid plexuses and enfoldings of choroidal arteries of the pia mater. And of course, you would have these plexi developing within the roof of the third ventricle as well as the lateral ventricles. In order to secrete your ventricular fluid, which then becomes your CSF eventually. And this is just a picture outlining the development of the fourth ventricle, right, where we're seeing the telochoroidea that we would have just described, as well as the ependymal cells with your invagination to form your choroidal plexuses. So this is an overview of the ventricular system of the brain. So we know the brain contains the 4 ventricles, which would be the 2 lateral ventricles that we're seeing here, a third ventricle, and a fourth ventricle. And we know that 2 lateral ventricles communicate with the third via the interventricular foramen of Monro, and then the third ventricle communicates with the fourth ventricle through the cerebral aqueduct. And then the fourth ventricle is continuous below with the central canal of the spinal cord. And you also have a small dilatation at the inferior end, which is known as the terminal ventricle. So I would have touched on the pituitary gland earlier, and this is just really an overview of it, that it's ectodermal in origin. For the sake of completion, it develops from 2 sources: your upgrowth from your ectodermal roof of cystomodium or the hypophyseal diverticulum, known as Rathke's pouch, and then your downgrowth from your neuroectoderm of your diencephalon, your neurohypophyseal diverticulum. And then, of course, the pituitary gland, this contributes the double origin, the oral ectoderm as well as the neuroectoderm, meaning your hypophyseal diverticulum from the roof of the cystomodium and from your floor of your diencephalon. That double origin really explains why the pituitary gland is composed of 2 completely different types of tissue, meaning you have your glandular for your anterior lobe and you have your nervous tissue for your posterior lobe. Again, this is just going to really outline to us how the pituitary gland comes about. So by the 3rd week, you're going to have this hypophyseal diverticulum projecting from the roof of the cystomodium that we would have discovered, and it lies adjacent to the floor of the diencephalon. And then by the 5th week, it has elongated and constricted. So here we're seeing it becomes elongated, and then you have a constriction. And when it becomes constricted at its attachment, it gives a nipple-like appearance that we're seeing here. By that point, it comes in contact with the infundibulum, and that infundibulum is derived from your neurophysial diverticulum. Remember, we would have said there's the double origin. So that part is from your ventral downgrowth of your diencephalon. And then during the 6th week, the connection of the diverticulum with the oral cavity, which is seen in E and F, it degenerates. That connection degenerates. So what you have happening is the cells of the anterior wall of the hypophyseal diverticulum continue to proliferate, and they give rise to the pars anterior of the pituitary gland. And then later, an extension, the pars tuberalis of your anterior lobe, growing around your infundibular stem. And of course, your cells in your hypophyseal pouch, they don't really proliferate as much, and you end up with a thin, poorly defined pars intermedia. So in essence, this is how the double origin of the pituitary glands ends up giving us that formation. And again, this is just a photomicrograph showing the cerebral vesicles, and this is of a human embryo at about 50 days, right? We can see all the things we've spoken about: the choroid plexus, the corpus striatum, the thalamus, the hypothalamus, the hypophyseal diverticulum coming into play, as well as the ventricles that we would have touched on earlier. So on to the midbrain, now that we've covered the forebrain. So morphologically, the midbrain is really the most primitive of the brain vesicles. It generally retains a cylindrical form, and its narrowed cavity forms the cerebral aqueduct, which is continuous below with the 4th ventricle and above with the 3rd ventricle. All right. And this image is showing us the successive stages in the development of the midbrain. So you're going to have your sulcus limitans. Let's use that as our starting point, that it separates your alar plate from your basal plate on each side. And then what you have happening is that the neuroblasts in the basal plates, these are going to differentiate into neurons, forming nuclei, different nuclei, cranial nerve 3 and 4, and possibly the red nuclei, the substantia nigra, and some of the reticular formation. And then the marginal zone of each basal plate then enlarges considerably. And when it does that, it forms the basis of the basis pedunculi that you're going to see in this picture here in C. And what that does is that when you form that, you have descent of nerve fibers from the cerebral cortex to the lower motocenters, and then in the pons and to the spinal cord, and that would then be your corticopontine, your corticobulbar, and your corticospinal tracts. Your alar plates are not to be forgotten, because what we just talked about was the basal plates. The alar plates and the original roof plates then form your tectum, as we can see. And what that does is that the neuroblasts in the tectum and the alar plate, they then differentiate into your sensory nuclei of your superior and your inferior colliculi. So again, this is another view, a transverse section of your developing midbrain, basically at the level of the superior and the inferior colliculi respectively. And what's important here that we need to know is that we have the 4 swellings on the 4 colliculi on the posterior surface of the midbrain, which are the superior colliculi associated with your visual reflexes, and your inferior colliculi associated with your auditory reflexes. So moving on to your hindbrain, the cervical flexure, as we would have stated earlier, demarcates the hindbrain from the spinal cord. The pontine flexure, which is located in the future pontine region, divides that hindbrain into your caudal and your rostral parts, or your myelencephalon and your metencephalon. The myelencephalon becomes your medulla oblongata, your metencephalon becomes your pons and your cerebellum. And by now, we've understood that the cavity of the hindbrain becomes the 4th ventricle and the central canal in the medulla. So the myelencephalon, the walls of the hindbrain vesicle, they typically have your typical organization that you see in your neural tube, your anterior thickenings, which is your basal plates, and your posterior thickenings or your alar plate. And that is separated by your sulcus limitans, which we saw earlier. And at this level, they go on to form the motor nuclei of cranial nerves 9, 10, 11, and 12, and they're situated in the floor of the fourth ventricle, just medial to that sulcus limitans. And then the neurons of the alar plate from the sensory nuclei of cranial nerves 5, 8, 9, and 10, and the gracile and the cuneate nucleus as well, right? So this becomes very important. What we're seeing here is exactly what I just said, the development of the medulla oblongata. And we see the variant nerves exiting from the alar and the basal plate. So what's happening is that the roof plate becomes stretched, right? This roof plate right across here, it becomes stretched into a thin layer of ependymal tissue. Then the vascular mesenchyme lying in contact with that outer surface of the roof plate, it forms the pia mater, and together they form the tilia choroidea, as we outlined earlier. And then between the fourth and the fifth months, local reabsorption of that roof plate is going to occur. You're going to end up with your paired lateral foramina, and then your foramina of Luschka and median foramen of Magendie. And of course, these are going to allow the escape of the CSF, just producing the ventricles into the subarachnoid space. So the myelencephalon, rounding up, the neuroblasts in the basal plates of the medulla, like those in the spinal cord, develop into motor neurons. This is important as we need to know the organization of it from medial to lateral. The columns are as follows. You have your general somatic efferent, which would represent neurons of your hypoglossal nerve. Then you have your special visceral efferent, which would innervate muscles derived from your pharyngeal arches. And rounding up, you have your general visceral efferent, which would be your vagus and your glossopharyngeal nerves. So this is from the basal plates of the medulla, from medial to lateral, and we'll have an image to just kind of concrete that in your minds. And then in the alar plates of the medulla, you have it in 4 columns instead of 3. And medial to lateral, again, you have your general visceral afferent from your viscera, your special viscera receiving things such as taste, and then general somatic afferent from the surface of the head, special somatic from the air. And this outlines nicely what we're talking about in terms of your sensory columns and your motor columns, medial to lateral. You have 4 in terms of your sensory columns and 3 in terms of your motor columns. So moving on to your metencephalon, you have your pons arising from the anterior portion of your metencephalon. Of note, it also receives a cellular contribution from your alar part, and these neurons are going of the basal plate will then form your nuclei of cranial 5, 6, and 7. And the axons of these pontine nuclei, they go transversely to enter the developing cerebellum of the opposite side. And that's how you end up with your transverse pontine fibers and the middle cerebellar peduncle. So now, rounding up, we would see the cerebellum then is formed from the posterior part of the alar plates of the metencephalon. So what you have happening is these alar plates, they bend medially to form the rhombic lips right up here. So we see they're going medially. And when they bend medially and the alar plates enlarge, the lips are going to project caudally over that roof plate of the fourth ventricle to unite in the midline to form your cerebellum. So at about the 12th week, you have that small midline portion, your vermis, your 2 lateral portions, and in essence, your cerebellar hemispheres become recognized. And the next image that we're going to show you is at about the end of the 4th month, the fissures develop on the surface of the cerebellum, and you have that characteristic foliage or folia of the adult cerebellum gradually developing as we see. And of course, throughout this entire process, you're going to have neuroblasts being derived from the matrix cells in the ventricular zones, migrating towards the surface of the cerebellum, and giving rise to neurons, which would then form the cerebellar cortex. So it was a mouthful in terms of, the development of the brain itself. But now we're going to look into the second half of things in terms of the clinical correlates, what we see commonly, what we don't see so commonly, and just to touch a little bit on everything. So importantly, in terms of our clinical correlations, we need to know about our encephaloceles, microcephaly, or different hydrocephalus, or different malformations, as well as I'm going to just touch on periventricular hemorrhage because it becomes important. It's the second most common cause of death in preterm neonates, and mental deficiency. So in terms of encephaloceles, what is an encephalocele? It's a herniation of intracranial content through a defect in the cranium. So that can contain meninges, it can contain meninges and brain, meningoencephalocele, it can contain meninges, parts of the brain and parts of the ventricular system. And the types of encephaloceles are classified as occipital, parietal, basal, sincipital, and frontoethmoidal. Now, of note, the most common ones tend to be in the occipital region. There's several, over 30 different syndromes really that have been associated with an encephalocele. Some of the common ones would be, well, that's associated would be Fraser syndrome or an amniotic band syndrome. Now, encephaloceles, it occurs approximately once in every 2,000 births. And in terms of causative agents, you know, genetic and environmental factors have been implicated in the development, including your torch infections, which we know Toxoplasma, rubella, CMV. And there is some correlation with the use of, well, the lack of use of folate rather, but it's not been a clear correlation between it. So this table is really just showing the classification of the encephaloceles in terms of your occipital, your frontal, sincipital, and basal. And in essence, these are telling you the sites of the herniation and the location of the mass that you would see. Now, the exact mechanism, even though I would have outlined some of the risk factors, the exact mechanism for developing an encephalocele has not really been identified, but there are several theories. One of the most accepted theory is that there's a problem with the separation of the surface ectoderm from the neuroectoderm after you have the closure of the neural folds. And just to remind you, remember we said that that closes at day 25. So a problem before this day is going to produce an incomplete closure with a defect not covered by skin. So your anterior encephaloceles, the development occurs from an abnormal development of your foramen cecum. Basically, what you have happening is a diverticulum of dura usually projects anteriorly between your nasal and your frontal bone. So this would fall under your sincipital in essence. So these are your nasofrontal, nasoethmoidal, nasoorbital. Now that diverticulum is supposed to regress and the bone closes. But if it does not regress, the brain can herniate through that bony defect, and form an encephalocele. And this is an example of an infant with a large meningoencephalocele in the occipital area. And remember, I would have said that this tends to, the occipital ones are the most common. This is an MRI of a 1-day-old infant showing a meningocele. And we can see here, you know, that this is CSF, right, on the sagittal MRI. This is what it would look like. This is an example of the anterior ones, which would be the frontonasal encephalocele that we're seeing in the picture on the left. And this baby actually had surgery and to remove a frontonasal encephalocele. And we could see the same infant 3 months after surgery. So merencephaly is another one that we need to talk about. It's a severe defect of the calvaria in the brain that results from failure of the rostral neuropore to close during the 4th week. So obviously it results in the forebrain, the midbrain, most of the hindbrain being absent. So it tends to be a common lethal defect. It occurs in at least 1 in every 1,000 births. It tends to be more common in females and males. The statistics that were quoted was 2 to 4 times more common. And it actually is the most common serious defect still seen in stillborn fetuses. So in terms of what causes it, you have a multifactorial mode of inheritance in these merencephalies. And one of the giveaways is that these are the patients that you're going to see an excess of polyhydramnios during pregnancy, because obviously the fetus is going to lack the neural control for swallowing up the amniotic fluid. And this shows us a sonogram of a normal fetus at 12 weeks on the left, right? So in essence, we could see, and then at B, we could actually see, particularly in this one, the lack of or the absent calvaria represented, by the white arrow, right? And this was twins. Microcephaly is a neurodevelopmental disorder. It's a result of a reduction in brain growth. Your calvaria in your brain are small, your face tends to be normal size, and some of the implicating factors would be large amounts of ionizing radiation, infectious agents, and some of these infectious agents are still, your torch, cytomegalovirus, rubella, as well as Toxoplasma gondii, and certain drugs, maternal alcohol abuse during the fetal period. Within the US, it's thought that the latest statistics, is that there's about 25,000 infants diagnosed annually with this. And this is an example. An infant with microcephaly showing the typical normal size face, but a small neurocranium. And this defect tends to be associated with mental deficiency simply because the brain is underdeveloped. Agenesis of the corpus callosum, it's associated with more than 50 different congenital syndromes. So what it is that you have a complete or a partial abscess of your corpus callosum. It could be asymptomatic, it could have seizures, you could have mental deficiencies, just for the sake of, completion, I included that. Hydrocephalus is an abnormal increase in your volume of CSF within your skull, so you're going to have a significant enlargement of the head because of the imbalance between the production and the absorption of your CSF, because you have excess CSF in your ventricular system of the brain. And of course, this can result from either impaired circulation and absorption of your CSF, or in some cases, you can actually have an increased production by a choroid plexus adenoma, but anything that impaired circulation of your CSF is going to result from congenital aqueductal stenosis. Now, without getting in too much detail, remember that our hydrocephalus, we usually have obstructing or non-communicating hydrocephalus, in which all or part of the ventricular system is enlarged. So if all of the ventricles are enlarged, if the apertures of the fourth ventricle or the subarachnoid spaces are blocked, whereas if the lateral and the third ventricles are dilated when only the cerebral aqueduct is obstructed. Now, hydrocephalus that is resulting from an obstruction or obliteration of your subarachnoid cisterns or malformation of your arachnoid villi is going to be a non-obstructive or your communicating hydrocephalus. And this is just to show you the classic, picture of what these babies with hydrocephalus is going to look like. Your cranial sutures are going to be widely separated. The anterior fontanelle is going to be enlarged. The veins of the scalp could be distended as well, and you have that characteristic sunset eyes, or the eyes looking downwards. The ventricles of the brain become markedly dilated. And what you have happening in these cases, you also have thinning of the bones of the calvaria, a very prominent forehead, atrophy of your cerebral cortex, and your white matter and compression of your basal ganglia, as well as your diencephalon. So I would have touched on Dandy-Walker and Arnold-Chiari as well. So your Dandy-Walker malformation or syndrome is a rare congenital anomaly. A lot of these patients end up having hydrocephalus, or you find them with hydrocephalus at the time of diagnosis. And this is really a posterior fossa anomaly that is characterized by three things. You have agenesis or hypoplasia of your vermis, and cystic enlargement of your fourth ventricle, causing upward displacement of your tentorium and your torcular. So it's thought that this complex malformation tends to be initiated by two pathophysiological mechanisms, meaning your arrest of your vermian development and your failure of your fourth ventricle foramina to fenestrate, leading to enlargement and causing compression of your vermis. And this is where we would see it. We have the cyst, we see the compression of the cerebellum, as well as enlarged fourth ventricle. For the purposes of classification, it tends to be classified as a Dandy-Walker syndrome malformation, megacysterna magna, or a variant. But the details of that, we'd spare this presentation for that. Your Arnold-Chiari malformation tends to be the most common birth defect involving your cerebellum. So you have a tongue-like projection of your medulla and inferior displacement of the vermis of the cerebellum through that foramen magnum into the cervical canal. And I mean, this occurs really 1 in every 1,000 births, right? So the defect, what you end up having is a communicating hydrocephalus because your entire ventricular system becomes distended. The cause of it is uncertain. However, the posterior cranial fossa that they found is abnormally small in these infants. And this becomes important when we're talking about the classifications of them. Because, for instance, in patients with Chiari-1 malformation, the bones of the skull base are underdeveloped. So you have a reduced volume of your posterior fossa, the volume of which then becomes inadequate to contain the entire cerebellum in a sense. And that is how you have the displacement of the cerebellar tonsils through the foramen magnum. And then in Chiari type 2, the posterior fossa is even smaller than in Chiari type 1. Of course, Chiari type 1 tends to be least severe and often found incidentally. Like I said, Chiari type 2, you have your brainstem herniation and torrent cerebellum. And of course, there's Chiari type 3 and a classification of Chiari type 4 that is now considered obsolete, more or less. Moving on to hydranencephaly, the cerebral hemispheres are absent or represented by membranous sacs. The brainstem is relatively intact. The thing is, these infants are going to appear normal at birth, but the head grows excessively after birth because of the accumulation of CSF. And mental development fails to occur, as you generally have little to no cognitive development, and again, causes fairly uncertain. Holoprosencephaly results from an incomplete separation of your cerebral hemispheres. These are the ones that tend to be associated with facial abnormalities. Tends to be severe and relatively common. You see it in about 1 in every 250 fetuses. Some of the risk factors or the environmental factors that have been implicated in this defect would be maternal diabetes, high doses of alcohol. These things, what they do is that they destroy the embryonic cells in the median plane of the embryonic disc back in the 3rd week. So you can have a wide range of birth defects resulting from a defective formation of the forebrain. And of course, like I would have said, you see a lot of facial abnormalities in these patients because they result from a reduction in the tissue of the frontonasal prominence. I included this as well, the periventricular and intraventricular hemorrhage, because, you know, this periventricular intraventricular hemorrhage, as I would have mentioned, is the 2nd most frequent cause of death in preterm infants and one of the leading causes of cerebral damage in preterm infants born less than 33 weeks of gestation. So the hemorrhage occurs when you have vessels of the germinal matrix in the periventricular area rupturing and extending into the intraventricular space. When that extends further into the intraparenchymal space next to the ventricle, it's termed a periventricular hemorrhage. So that germinal matrix that I speak of, it's an immature thin wall. It's really a capillary network located on the head of the caudate nucleus and underneath that ventricular ependymon. And what you have happening is that these vessels can be very fragile, and particularly in the preterm neonates, and you're going to have immature cerebral autoregulation as well. So in these neonates, 24 to 32 weeks, you know, less than 33 weeks, they have this highly vascular collection of, you know, glial and neuronal precursor cells, and that germinal matrix encircles the lateral ventricle, but it tends to be more prominent on the caudate nucleus. So what you have happening is when it becomes, because that vasculature is fragile, anything that's going to disturb that cerebral blood flow or any coagulation disorder can contribute to rupturing. You can also have spontaneous rupture of it because of it occurs in settings of hypoxia, fluctuation of any kind of cerebral blood flow, and so we know that neonates, they tend to be on mechanical ventilation, hypocarbia, pneumothorax, they tend to have respiratory distress syndrome. All of these things can contribute to ending up with periventricular, intraventricular hemorrhage. And then finally, mental deficiency, congenital impairment of intelligence comes from a wide range of genetically determined conditions, including things such as Down syndrome. It results from an action of chromosomal abnormality, you know, 13, 17, 21. Maternal and fetal infections can do it as well. They're commonly associated with it. Maternal alcohol abuse, again, is a common identifiable cause of mental deficiency. The thing is that 8 to 16 week period of human development is really the greatest, or the period of, or rather, I should say, the period of greatest sensitivity for fetal brain damage, especially, if the mother is exposed to large doses of radiation, because really by the end of the 16th week, most of your neuronal proliferation and cell migration to your cerebral cortex are completed. So at that point, you're at risk of severe mental deficiency. And of course, other things can do it: birth injuries, toxins such as lead, cerebral infections. I don't need to go through those again. And of course, trauma from head injuries, disorders of protein, carbohydrate, or even fat metabolism can also contribute to mental deficiency. And that sums up the presentation on development of the brain and the common anomalies that we can see as a result.